you, Mr. Isaac, for the kind introduction. I also like to thank the organizer for the invitation to this very important event. The topic that I am presenting today is cost of cancer care. Obviously, it's a very big area and profoundly heavy. However, I'm only given 20 minutes, so I'm just gonna touch and go. So if you see some areas where I am too brief or overly simplifying matters, just bear with me. Okay, we'll organize longer sessions later on when there is an opportunity. Okay, so where's the pointing? Okay, so for the next 20 minutes or so, I'm going to be talking on these few topics. So I'll start with what are the causes of all these troubles that we're facing. And from a health economist point of view, I think it's mainly due to two reasons. First is the way that our healthcare is financed. And secondly, there are a number of factors that are causing the recent high expenditures. And then I will suggest perhaps a couple of fixes that may or may not help, but I mean just proposing something. And then I have a brief summary of the messages. So what are the causes of the trouble that we are having? I think the first cause, as I said, is due to the way that our healthcare finance system. Around the world, there are at least 6 or 7 different models of healthcare financing system. And of course, in some countries, for example, our neighbor Singapore is using combination of 2 or more. So usually, I only listed out 5 here. So the one with the oldest tradition is perhaps the National Health Service, or NHS, and this is exactly what we are having in Malaysia. I'll talk a little bit in more details later on. And then we have social health insurance, national health insurance. I will very briefly touch on this third model just before I close. And then voluntary health insurance. And then another very relevant healthcare system is out-of-pocket payment. So as the name implies, patient pay everything out of pocket. So of all this healthcare system, one thing that we have to be very careful with is there is nothing. There is no such thing as one size would fit all. So every country will need to adopt its own healthcare financing system based on their population, their socio-economic status, the local epidemiology, the local healthcare facilities, etc., etc. So this is the different systems. So just to touch on very briefly about the NHS. NHS is also called the beverage model. Healthcare provision is provided at first point of contact and funded by direct income tax deductions. And therefore, this system is heavily relying on taxation. Government is responsible for gathering all the taxation to provide the health service, which is provided upfront, with the tax money. Majority of hospitals are owned and operated by the government. Thank you. Operated by the government. And the healthcare professional working in those hospitals, doctors, nurses, are all considered as civil servants. So this is very much like what we're doing in Malaysia, right? Now the other healthcare system, as I said just now, is out-of-pocket, OOP. OOP is very commonly adopted in those more rural or less developed areas or countries. As the name implies, patients must pay for their healthcare out of pocket. This system, the main problem with this system is it allows the wealthy to get the professional, better medical care, and the poor don't, unless they can somehow come up with their own resources. So therefore, it is considered to be the main cause of inequity and financial hardship and toxicity. Now, financial hardship or toxicity arises when the poor try to get the latest medicine, the expensive one, but because of their financial status, they cannot afford it. So what they do is either they sell their properties or stop their kids from going to education. So all this will end up in financial hardship, or a more recent term is we call it financial toxicity. And because of this reason, WHO's recommendation is all countries should limit their OOP expenditure within 30 to 40% of the overall healthcare expenditures. So, apart from healthcare financing, there are also other reasons that cause us the trouble, and these are some of the reasons contributing to increased healthcare expenditures in cancer care. I list out 6 here, but I don't have time to go through each one of them, except one. Perhaps I'll go through this one in a little bit more detail. So, demographic transition of population is something that we all realize, and then other factors would include low regulatory bars for adoption of the latest tests and treatments, defensive medicine, futile care, especially for patients who are terminal, and then in the market there are usually a lot of distorted incentives. And then last but not least is a misallocation of resources. Problem for individuals and societies where resources are finite but demand is infinite. So let's look at the first factor, which is very much close to my heart, which is the demographic transition of populations. This is due to increased prevalence linked to population aging, and also due to success in reducing mortality from other diseases because of the advancement in healthcare and the discovery of new drugs, and all these reasons. And the end result is that there's a growth in the aged population. Now let's look at some data. This is from DOSN, the Department of Statistics of Malaysia. Malaysians are living longer and longer compared to about half a century ago. You see, female and male are both living much longer. Now, living longer is not necessarily, well, it's a mean word to say. Living longer is perhaps not good for the society in terms of healthcare. Reason, if we look at this bars, I mean, it's something that everyone here need to be worried about. So if you look at, well, these are the age structure over a period of 10 years. If you look at the gray areas of each bar, you can see that over these 10 years, the gray part, which represents the 65-year or above group, is increasing more and more. Compared with 10 years ago, there is in fact a 40% increase, 40% compared to 10 years ago. But if you look at the very young population, who are 1-year-old, 14-year-old at this moment, there's a slight shrinkage, although not bad, not as bad as this one, is still a 15% shrinkage. So imagine if this group in 10 or 15 years, they move to this age group and start to be taxed or have to start paying tax to the government. So how can they afford this aging population? So who is going to pay the bill? That's the main question in 10 or 15 years' time. Now, come back to cancer. The incidence of cancer has been increasing all along, both male and female. So the sort of the starting off age is roughly 45 to 50. So all of a sudden start to go rocket high. This is another graph showing that the number of cases by age group is both male and female lies within 55 and 70. So this is the main group of cancer patients, both male and female. Looking at the incidence provided by MNCR, the Ministry of, the Malaysia National Cancer Registry, you can also see an increase in the number of cases. About over a period of 10 years. The increase is about 20%, both male and female. This slide shows the rapidly rising cost of cancer. This is published in a paper in New England Journal of Medicine back in 2009. The data may be a bit old, however, if you look at here, I think this trend is going to be pretty much the same. The cost of cancer rise 5 times faster than other classes of medicine. This rise started to be obvious around 1990. Now this is another article submitted by an American doctor and came up in Fortune a few years back. So he reported, or he estimated that there is an average cost of cancer drug in order to deliver a life year. So back in 2014, the cost is about 225,000 US compared to about 20 years ago. That's a 4-fold increase, 400 times increase. 400% increase. So back to Malaysia, let's look at the healthcare expenditure on cancer treatment. Now this is the overall expenditure on drugs. So this whole block data is on drugs. When it comes to cancer, is here. This is the number. The expenditure on cancer drugs over the past 4 years. So in terms of percentage, I think it sort of stays pretty stable. However, if you look at the actual number, it increased by 20%. Okay? 20% is a big sum of money. So if we look at the whole world, we can see a general increase in healthcare expenditure over a period of 20 years. So all the line on all the curves are moving upwards. This is obviously the biggest spender, which is the US, and Malaysia is here. Malaysia is here. You can also see there's an increase in expenditure over the year. However, we are spending more, but what is worrying is actually the OOP. I briefly mentioned just now. This slide may not be too clear because the color, but this is OOP of Malaysia in 2011, and this is OOP in Malaysia by 2021. So over a period of 20 years, it increased from 12% to almost 16%. So 25% increase in OOP compared to 10 years ago. And then looking at this slide, now remember when I first introduced OOP, I said OOP is usually adopted by mainly rural areas or countries of lower socio-economic status. However, you look at this graph, when Malaysia is compared with other ASEAN countries, you can see most other ASEAN countries are decreasing their OOP over a period of 2010 to 2014, perhaps except Cambodia. But look at Malaysia, we're increasing. So it means the problem of OOP is getting worse. So all this healthcare expenditure, all this change in demography actually lead to a lot of undesirable outcomes. So this include universal healthcare will be jeopardized. Universal healthcare is something that Malaysia is proud of over the years. Because at the moment our OOP stands at 34.2, is pretty much touching the ceiling of the WHO's recommendation, and because of that, there is increasing inequity in accessing healthcare, especially for the lower socioeconomic populations. And alongside of that comes financial toxicity as well. And then when all this blend together, our healthcare system becomes very unstable. So at this juncture, the questions that arise really include, these three. These three are among the questions that we have. Are we paying the right cost for the service? Are we able to maximize the benefits with our spending, which is keep going upward? Is the level of spending sustainable? If it is the case, are we able to continue to be spending like this? So, some potential fixes may not be immediate, but it may help. So, first of all, is instead of relying on NHS entirely, and out of pocket, I would say having another system to be brought in, which is the National Health Insurance model. National Health Insurance model is actually a type of insurance model, but the insurance is run and operated by the government. So it's sort of like some European countries where you pay tax and then you get the insurance. And if there's not enough, the government will top up with general revenues or general taxation. So with that, I think there comes another fixes is all this spending. We are concentrating on the dollar sign only, but are we using the money wisely? So this is where value-based healthcare comes in. Value-based healthcare is nothing new because it is part of the the Affordable Care Act, or ACA, brought in the year of 2010 by the then US President Obama, and therefore it is often called Obamacare. In the framework, just in a nutshell, what it is instead of paying for quantity for healthcare, we pay for quality instead. So value-based healthcare is not a fee for service, but fee for value. So value is a very vague term for what is value. Not long ago, the Institute of Medicine in the US has developed the so-called STEEP methodology that describes high-value care. Safe, timely, effective, efficient, equitable, and most important of all is quality of life, which is built around the patient. So before I close, I just like to draw your reference to the health white paper that came out earlier this year. What I've said just now over the past 15 or 20 minutes or so is pretty much in line with the pillar 3 of the healthcare white paper, which says government will increase investment for health, although it's not explicitly mentioned here that they will establish a new healthcare system, but somewhere in the health paper, if you look at it, it mentioned that this increase in investment will be contributory in nature. And then also in terms of spending money, the healthcare paper recommends that we should ensure effective, efficient healthcare spending. So this is what I just talked about. So these are the messages to take home with. I think universal healthcare in Malaysia is at stake at the moment due to changing demographics as well as the scarcity in healthcare resources. The way healthcare finance must be restructured, and cancer care should be measured in terms of value rather than unit cost. So with that, ladies and gentlemen, I conclude my presentation. Thank you.